Hi, everyone. Welcome to day 2 of the Washington State 2020 Medicaid Integration Summit. Next slide. So as we gather virtually from various locations across the state of Washington, we humbly acknowledge that we are all meeting on traditional territories of hundreds of indigenous tribes. As managed care organizations, we are committed to upholding tribal sovereignty through our dedication to addressing the health disparities amongst AN communities caused by historical systematic racism. For more information about the land that you occupy, see the link in the chat. So again, welcome everyone to the second day of the summit. Thank you for joining us. So before we get started, I'm Stephanie Shushan. I am a senior analyst for integrated programs and strategic initiatives at Community Health Plan of Washington. And I will be the host of the summit on behalf of all 5 of the Medicaid managed care organizations. So before we jump into the first presentation, next slide. Some housekeeping items. So attendees will be muted throughout the presentation. You can use the chat function for comments or tech issues, and any questions that you would like directed to the presenters should be submitted in the questions box on the right-hand side. We will track these questions and address them at the end of the presentation as we have time, or we have the capacity to follow up as well if we don't get to those questions. And the webinar is being recorded. So you can find the handouts on the side of the panel. And we will be also sending certificates out from GoToWebinar for participation for day 2. Also, at the end of the day or tomorrow, you'll be getting an email from GoToWebinar with an evaluation form, and we would really appreciate you filling that out to inform our planning for these webinars. So to start the afternoon off, I'm going to hand off to Andrea Ray for our first presentation. So these are our presentations. We will have 5-minute breaks between the presentations. So again, the first presentation is care coordination and shared care planning. So Andrea Ray is a senior clinical practice performance consultant for United Healthcare. She's a licensed mental health counselor. She has over 20 years of experience in behavioral health, which include pioneering many integrated mental health and SUD programs. She was program lead for one of the early CCOs for health home services in Washington. And she has a certificate from the University of Massachusetts in behavioral health and primary care. For the last several years, she has worked on further integration of primary care and behavioral health. So Andrea will be facilitating this session and also presenting. So Andrea, take it away.
Thank you. So is everything coming through okay?
Sure is.
Excellent, good. Okay, well, welcome everyone. I have the pleasure of introducing now our next presenter for this panel. So I have a total of 4 people that are going to be speaking during this hour. The first one is Susanna Petrie, and she, just to give a little bit of background, she has worked in her past on a surgical floor in Auburn, California. She did that for 17 years, so I thought that was pretty spectacular. She earned her RN in 2013 and her master's degree in nursing leadership in healthcare administration in 2015. She also achieved her National Case Management certification in 2017. She's currently serving on the board of directors of the American Case Management Association. And Susanna has been with CMAR since 2017, and she is a program manager for transitions of care. So welcome, Susanna.
Well, thank you, and thank you for the introduction, and thank you everybody for joining us today. So I'm going to be talking to you about our program, Transitions of Care. You can go on to the next slide. So Transitions of Care, the way we've designed our program, it's a voluntary 30-day case management care coordination effort program for active CMAR individuals who have been admitted to acute care with a medical diagnosis that will be discharged home to self-care. So in other words, we are not focusing on anybody who will have any kind of outpatient case management because we don't want to be duplicating services. Exclusions apply, so we're not looking at OB, we're not looking at planned surgeries or primary behavioral health or substance use disorders. They have to be truly sick, admitted to an acute care, and going home to self-care, because those are the ones who fall through the crack and wind up being readmitted. So next slide. So really, the transitions of care, it's a trifecta of good. So we are improving client outcomes through reduced readmissions and reduced admissions. We are doing patient education for symptom management and proper utilization of healthcare resources. We are providing medication reconciliation post-discharge. We are having improved quality of life for our patients. So really, the biggest and the most important outcome of what we're doing is improve client outcomes. The other benefit of what we are doing is increasing revenue for CMAR. Our providers can bill for transitional care management, which gives us a higher rate of reimbursement for their services. And the third benefit to what we do is preventing hospitals from being dinged by CMS. When their readmission rates are higher than the national average for like hospitals, they wind up getting a reduced readmission rate. So when we reduce readmissions, then our hospitals that we serve throughout the state of Washington are not being dinged as well. So really, it's a threefold improvement for what we're doing. So next slide. So I wanted to highlight two different studies that really articulate why we do what we do. The first one was an insurer-driven study. Patients in care management received a phone call from a pharmacist 3 to 7 days post-discharge for medication therapy assessment and reconciliation, and were identified as a medication review group. Patients who did not receive clinical pharmacist intervention were included in a comparison group. And what they found was that individuals who received this medication therapy assessment and reconciliation had a decreased readmission rates at day 7, 14, and 30 post-discharge. And most statistically significant were at days 7 and 14. One of the really astounding outcomes from this study was the financial savings was that per 100 individuals who received that medication reconciliation, there was an estimated $35,000 savings, which translates into more than $1.5 million, excuse me, in savings annually. It also highlights that more than 80% of unnecessary readmissions is caused by medication discrepancies because they had at least one medication discrepancy upon discharge. So next slide. The next study that I wanted to highlight was a study that was also an insurer-driven study that had pharmacists conducting in-home and telephone medication reconciliation post-discharge. The patients also received personal adherence education and coaching, and they also received an individualized care plan. But of those program participants, they had a 50% reduced relative risk for readmission within 30 days of discharge, and an absolute risk reduction of 11.1%, which translated into a savings of more than $2 for every $1 spent. So both of these studies highlight the cost savings of a transition of care program. So what this program looks like, on admission, my staff, my nurses and my community health workers, they pull an EDI report, and that's the Emergency Department Information Exchange, to get the inpatient admission list for the previous 24 hours. They will do a chart review. They will print demographic and a medication sheet in order for them to take it to the hospital. They will perform a risk assessment at bedside, and they will introduce the concept of zones, green, red, yellow zones for symptom management. They will talk to the patient about Ask Me 3, which I will go into greater detail farther into the presentation. But they will also notify the PCP of the inpatient admission, which is one of the key components of this, because communication with the primary provider is essential to managing them once they're outpatient. They will also schedule them a follow-up appointment, and they will schedule a home visit in order to do that medication reconciliation. So all of that takes place while the patient is still inpatient. So next slide. So within 48 hours of discharge, my staff will be placing phone calls within 2 business days of discharge for all individuals. They will be assessing medication, transportation, durable medical equipment needs. Oftentimes, patients won't be able to afford medication, or they won't have transportation to their follow-up appointment. They may not have electricity at home, and they may need refrigerated insulin. Assessing all these needs immediately post-discharge is absolutely critical to making sure that these patients are not going to wind up back in the hospital. We need to make sure that their primary care provider is provided with the discharge summary so that at their follow-up appointment, they know how to address their issues. And we can verify our home visit for medic reconciliation. So next slide. So within the first week after discharge, we will go to the provider appointment if the patient wants us to, but we need to make sure at least that they have an appointment within 7 days of post-discharge, especially if they're in the moderate to high risk category, and for most Medicaid and Medicare individuals. We also want to ensure that we have done that medication reconciliation prior to that discharge appointment, because that is one of the criteria for being able to bill for a TCM appointment for our providers. And then any other additional phone calls, contacts, if we need to contact pharmacies or any other social services, we can also make all those phone calls within that 7-day post-discharge period. So next slide. So weeks 2 to 4, all the heavy lifting has been done already. We just need to make sure if they haven't had their provider appointment within the 7 days, that they would have one within that 14-day window. We would also just be making phone contact for the majority of patients on week 2, 3, and 4. And if they are really high acuity, the staff have the ability to use their clinical judgment if they need a home visit. So we will be touching base with them at least weekly during weeks 2, 3, and 4. So continue, please. Next slide. So the care coordination aspect of this program is foundational to our success. During this process, the staff are making referrals to behavioral health, to substance use disorder treatments, because even though we don't see those as primary diagnoses, a lot of these sick patients, even if they're admitted with a medical diagnosis, they will have behavioral health issues or substance use issues. So as long as it's not a primary diagnosis, they would not be excluded from our program, and we do try and help them get into treatment. We look at all the community resources, we look at food banks and any other community associations, community action councils that we can get them into. We assist them with bus passes, dial-a-ride, any kind of transportation needs that they have. And then most importantly, we try and transition them into our long-term case management program. We can't change their world in 30 days, but we can point them in the right direction. So we have other programs with health homes, pathways, and in some counties we have chats, community health action teams, and up in Whatcom we have GRACE, so which is a ground level response that also looks at law enforcement and utilization as drivers. We want to get as many of our folks into these long-term programs as possible. And of course, we can facilitate any specialty visits that they might need. That's fine, go ahead. So some of the tools that we use to do what we do is the readmission risk assessment. So we will go through, this is loosely based on the 8 Ps, which is another nationally standardized transition of care model, but all of these models are focused on the inpatient side, whereas we are community oriented. So we took this and we adapted it to our needs, looking at multiple medications, looking at oxygen needs, looking at health literacy, looking at prior hospitalizations, and other social determinants of health in order to give us a score that will tell us what the readmission risk assessment is. So next slide. So this is the Ask Me 3 that I was talking about earlier. It is essentially addressing the issue of health literacy because nearly 9 out of 10 adults have difficulty using everyday health information that is routinely available in our healthcare facilities, even retail outlets, media, and the communities. So low health literacy will cost the United States $236 billion a year. They have higher rates of hospitalization, emergency care visits. They experience more preventable hospital visits and admissions and have higher medical costs. So this Ask Me 3 specifically looks at, it teaches the patient to communicate with their provider these 3 questions. What is my main problem? What do I need to do about it? And why is it important that I do that? This program was created by the Partnership for Clear Health through the IHI and Pfizer Pharmaceuticals, and it's licensed. It assists patients in becoming more involved with their health care. It organizes the conversation between the client and the primary care provider and focuses the discussion to the absolute essentials so they don't feel overwhelmed. Yeah, you can go on to the next slide. And one of the last tools that we use is the teach back method, which may seem oversimplified, but it is to check patients' understanding using this method to have them repeat what it is that you've just taught them. If patients cannot explain what they've been told, assume that you have not clearly communicated with this information, and you would commence the explanation all over again until they had a clear understanding of what you were trying to teach them. Next slide, please. So I wanted to go over some success stories with you that would give you a broad understanding of how this program works and all the care coordination that is involved in these. This client from Pierce County was discharged to homelessness following traumatic motor vehicle accident where he sustained several facial scalp lacerations and a right hip dislocation, a right anterior femoral head fracture, and underwent surgery on his hip. He was discharged by wheelchair to a friend who was not involved in any discharge teaching. Discharge instructions were immediately lost. Client experienced poor short-term memory. Hospital records were not accessible due to client being admitted under an alias, and merging of records delayed by 2 weeks. Client was not contacted by any specialty providers, but my staff was able to schedule follow-up appointments. They reminded the client the day prior, called client following each one for teach back, assisted client in navigating healthcare system due to poor health literacy and ongoing confusion and memory issues from the motor vehicle accident. They communicated with the PCB regarding primary issues, requested relevant referrals, referred to pathways for long-term care management, gave a warm handoff to an assigned community health worker, and coordinated care management during the final week of TOC. Referred to behavioral health related to anxiety, depression, and poor coping, and instructed client an open access process for behavioral health if he was not contacted. We also engaged them with motivational interviewing in order to strengthen engagement and strengths-based support. So that gives you a really broad picture of what it is that we do. So next slide, please. Am I out of time?
Yeah, well, we are, yes, running a little bit behind.
That's okay.
But if you, did you want to sum up? I know we have a few more stories, but maybe we could move past those. And if you want to give a quick summary, what do you think?
Sure, no problem. Yeah,
Okay.
care coordination, especially for FQHCs, is around 13%. So when we are engaging in this, intensive care coordination post-discharge, we can get that readmission rate down to below 7%. So care coordination is essential to helping these patients. So thank you for your time. I appreciate it.
Thank you, Susanna. Hey, quick question. Just as we transition over to our peer support specialist, can you see transitions of care working really well for behavioral health needs as well? I know you had a lot of medical focus, but do you see this also for behavioral health?
Definitely.
Discharges?
I mean, it's a different specialty because it has different drivers, but the concept itself would be extremely, yeah, it would be very beneficial.
Awesome. Thank you, Susanna.
Yes, thank you.
Okay, I'm going to transition over just in voice to Tohmas Hunke, and he is a peer support specialist for United Healthcare. He is going to do his own introduction, so I'm excited to have him speak to his lived experience and the whole person care model in action. Tohmas, do you have your...
Hi, sorry, I didn't want
are.
to get in too quickly, but hello. Hopefully you guys can see me too. Hi, everyone. Clearly I am in my kitchen, but it is so good to be with everyone. Thank you so much, Susanna. It was so good hearing all those statistics and all the things that I didn't really think about and I don't really put an effort into all the time. So I'm thinking, what's my next move? Who do I have to email? What do I have to think about? And seeing all the work actually laid out in front of me was kind of cool because I didn't ever really think about it. I kind of just assumed it came nowhere, but to see every work is really, really incredible and really honestly. But my name is Tohmas. I am a peer support specialist with United Healthcare. I have been with UHC for 4 or 5 years-ish, maybe, I want to say. But besides that, I am in Seattle, Washington. I live kind of in Lake City, so if y'all are in the area, want to stop by, well, not because of COVID, but if you ever want to stop by and say hello, please do. I work with a team in Texas. They primarily work on the Texas Star Kids team, and right now I'm with Robert, and I can't even pronounce his own last name. He's a manager right now, but Andrade, but he is the manager right now, and he is super fantastic in helping me kind of do what I do, which is primarily focused on member relations and being a peer support specialist, obviously, but doing the best I can in terms of how do we really make an impact in members' lives. And it's always a big question of what are we doing and how can we do it better? And not about the integrated care, but in terms of member care specialists, obviously I am not foreign to the real health world, and I have my own lived experience, and lived experience in and of itself is such a bizarre topic to talk about because it's such a gauntlet. I want to say it's such a heavy-hitting word to say yes, this is lived experience. Lived experience in and of itself is where you have your own backstory in your own life, obviously as everyone else does, but more so that sense of, okay, I've had depression, I've had anxiety, and going forward with using we were given, or making a development plan for how to take care of yourself or how others can help take care of you in that way, whether it's your clinicians, whether it's your family, any support system you have. And so moving forward with whatever you're going through, whether it's someone who's living with schizophrenia, someone who's living with alcohol, whatever it is, building forward for yourself with that experience. And that's what we call lived experience. I don't know if I'm over speaking on my time. I'm speaking very fast, so I apologize. we do kind of a lot of everything, whether it's working with members to help mitigate ER visits, whether it's helping them get back to school, or whether it's someone who really wants to adopt a cat, because believe it or not, I've helped many a member adopt a cat. But
Yeah,
all in all,
Thomas.
it's really.
Sorry, this is Andrea. You are
Hi.
doing a wonderful job, by the way. I didn't want you to worry about the time. The only reason I popped my head on is because you did have a little bit of sound difficulty, so I just want to make sure we could hear everything you're saying. So, but you're doing okay. I still can hear it. It just once in a while goes out a little bit. So, but you're doing great. No, you're doing great.
I will be fully honest, my desk is against a wall and they're doing construction right now. So I was really hoping that nothing would come through or I wouldn't break out, but clearly, you know, I guess that's just life during COVID. You get interruptions when you don't want to.
No, that sounds great now. It sounds great now. So thank you.
Sorry. With that being said, with my embarrassment in the past, because you just move forward one step at a time, I think a big part of lived experience is just how it ingratiates itself to the whole person care model. And the whole person care model is where you have an entire team of people working for one particular member. And like, obviously it's not all hands on deck all the time. There's going to be kind of a baton pass of like, hey, Tom, you're a peer support specialist. You're going to work with Lacey Malonis, and she's a behavioral healthcare advocate. She's fantastic. She's going to help with a lot of the clinical stuff because clearly you're not a clinician, which is great. You were hired for your lived experience. That's kind of how that plays into the whole person care model. Being able to have and use and intertwine multiple different strengths and honestly, just like the conglomerate of having a huge team like that, you have such a roundabout way of really caring for each member and what they need and each tailored interest. And whether that's shifting from someone who's a community health worker, where they're really helping members link up with their appointments and their medical needs, and RN who has extreme knowledge on medical history, and a behavioral health care advocate who are licensed mental health professionals. They're all so knowledgeable, and to have such a team come together and take care of a member, it's kind of why it works the way it does so well. And I'm not tooting my own horn, but I love what I do, and I think it's a really great mission all the time. But also having a team of people who are literally just on fire rock stars is also fantastic. It's kind of in the blood if you have a whole bunch of people who are trying to do their best, kind of thing. So that's where I come from and do my job and do what I do. But obviously, I'm a quirky little guy with a lot of stuff and a lot of fast words coming out all the time. But it was so good to talk to you guys, and thank you so much for having me. And I'll pass the baton to Andrea.
Thank you, Thomas. I think you explained so well how putting all those pieces together is important for people, and that's kind of what we're talking about in care coordination and shared care planning. Thank you so much for sharing that with us. Yeah.
Cheers, everyone. Bye-bye. Well, for now, I'm on the call, but you know, my video is going to be gone. But cheers. Thank you so much.
Thank you. Okay. So, thanks, everybody. I'm going to now go next, and let me see if I can get my slide to advance. Okay, so I'm going to talk about shared care planning. This presentation is going to take you through the background, the definition of shared care planning, benefits of shared care planning, and some key components, along with some implementation strategies. When you're talking about shared care planning, this has been around for a while, and there's a lot of research about shared care planning that's taken place. As you know, Washington began transforming to integrated managed care in 2019. A central component of that transformation is improving quality care coordination, and that's provided by clinicians to individuals. So care planning has a long history. So it's been in acute care settings, it's been with individuals with complex needs, in behavioral health, end-stage renal disease, intellectual and developmental disabilities, and of course, HIV and AIDS. So back in 2015, the US Department of Health and Human Services, they convened together and they created a vision for what a shared care plan would look like. So a lot of the materials in this come from that vision. A shared care plan is a client-centered and and is designated to facilitate communication among members of a care team, including, of course, the individual and providers. A shared care plan combines both behavioral health and medical plans of care. And these are, of course, individual service plans or treatment plans. And this is to encourage a team approach to their care. Important things you want to remember is that there are several benefits to doing a shared care plan. It gives the individual an opportunity to really develop and negotiate their plan. It helps transform that relationship between individuals and their providers, really gives them a voice. A shared care plan is a tool to exchange clinical information, and also, importantly, that kind of ties into our other presentation, to reconcile medication and really understand that. It's also an opportunity to coordinate with primary care, behavioral health, and other members of a care team in order to improve quality of care outcomes. There are some key components. A shared care plan really requires participation by multiple members, as I've said, and it includes some or all of the following elements. So there have to be team roles and goals. So the team members are responsible for specific goals and tasks. So you want to include those who have permission to exchange information, as that's an important part of it. And then also, you want to make sure that you document the conversation with the member. So if you cover anything about the benefits of the shared care plan, any risks or concerns about, and then of course covering confidentiality. So you want to document that. You also want to be sure that you consider cultural competency discussions, such as their preferences of what the individual wants to be called by their care team. Sexual identity, I missed the pronoun, so he, she, they, racial, religious. So consider all those things that could play a part in someone's care. Names and roles of community-based support or other outside services that they may have. A brief overview of their health status, and then each episode of care, what has happened. Advanced directives, and a summary of their shared care plan decisions that have to take place. Even talk about conflicts that may arise. That's important as well. When you are, let's go to the next one here. I want to cover the actions to implement. So ensure that you have a behavioral health assessment if you're in a primary care setting, and then ensure that you have a medical assessment of some subtype in a behavioral health setting. And we'll probably have some resources at the end of this for those screenings and assessments. Train staff to use SBIRT, screening, brief intervention, referral to treatment, the PHQ-9, and there's a whole load of other screening tools that you can use. Have follow-up mechanisms for external referrals and the care team stakeholders. A few more things, ensure that there's access to both medical and behavioral health specialists on your team. All prescribers are communicating together. That's really important. Train staff on SMART goals, and train your staff, of course, on motivational interviewing and behavioral activation, two very significant parts of coordinating care with anybody. There are some considerations for special populations. You want to look at shared care plans for individuals with disabilities, intellectual disabilities, or developmental. That requires consideration of other services that they might be getting. So ensure that you're communicating with those state agencies or other providers. And then for children, you want to consider their educational or school system, and of course parents and other family members. And then one more special population, foster care, of course requires collaboration with the state agency that has medical guardianship. And last but not least, a resource list. I want to highlight The bottom one here, this is really some great resources on reducing stigma with the language that we use as professionals. If you're developing care plans, shared care plans, you want to make sure that you're very aware of the language that's most helpful to the individuals that we work with. I am now going to give some time, I hope plenty of time, for Jenna. Let me get to her. Oops, too many slides. Jenna joins us, and she is Jenna Bowman. She is an enrolled member of the Tulalip tribe of Washington. She has a dual master's degree, which is super exciting, and she's working on her PhD in philosophy, along with Indigenous studies. She has a lot of interest in creating, developing, and implementing tribal law to protect vulnerable and disabled Indigenous members from abuse, neglect, and exploitation. She has successfully created a community health department within an indigenous community to eliminate the barriers and improve the overall health of the entire community. Jenna is now currently working to develop and implement opportunities that will support Indigenous populations in an effort to promote health throughout culture and tradition. Thank you so much, Jenna, for joining us.
Thank you.
Well, there you are. Thank you.
Good afternoon, everyone. Adzales y Jenna. My traditional name is Adzales, but I go by Jenna. So today I'm just going to share a story. This is Ruth's story, and I think it's really important in the context of everything that we're talking about, especially when it comes to care coordination and wraparound services in its all intents and purposes. So as a young girl in a boarding school, one of Ruth's most vivid memories of non-traditional medicine or of Western medicine was experienced with her diagnosis of TB in the boarding school. The experience was hostile, frightening, and authoritative, and Ruth had quickly learned not to argue or question or to even make eye contact, and especially not to disagree with what was said. Ruth's diagnosis was considered a problem, and the school immediately had to have her removed. She was supposed to return home, but she soon discovered that her mother had left after Ruth had been taken to the boarding school. So in an effort to send her home, the school returned her to live with her grandmother instead, because that was the only person they could find. Ruth soon discovered that her grandmother practiced traditional healing, but it was done secretly at home. Ruth really understood this because after experiencing the boarding school, like I said, she knew not to argue. She didn't understand the things that were said to her. And it was authoritative. It was done in a tone of, you will do this. There wasn't a question about, would you like to or can you? So that was her younger years. Later in life, Ruth married. She began to have a family of her own. This is when Ruth began experiencing unexplained issues with her health. One instance led her to being rushed to an emergency room for an evaluation. The physician diagnosed her with complications related to alcoholism, and no other family members were present. She was given paperwork full of medical jargon, a referral to CPS for possible neglect of her children, and sent home with a note about non-compliance of medical directions and lack of concern about her own health care. Mind you, Ruth does not drink. After many more instances of unexplained health issues, Ruth's family helped her begin care with the local Indian healthcare provider at the tribal clinic, where she was diagnosed with diabetes. With each pursuing issue, Ruth was seen at the Indian healthcare clinic, but with limited hours and limited resources at the clinic, she was often seen at the local hospital. The hospital system did not communicate with the tribal clinic, and the information from the hospital staff was never communicated to anyone other than Ruth. On one of Ruth's last admissions to the hospital, the medicine that was prescribed had a negative effect with the medication that she'd been given from her tribal provider. Ruth was sent home and placed on hospice, where she passed a few days later. When you listen to this story truly is about a family member of mine. This is about my grandmother, who you will see in the picture. Chokes me up a little because that's why I'm in healthcare. Things need to change and people need to have a voice. And they need to be able to do it in their own voice and in a way that's comfortable for them. So in my development of Tulalip's community health department, there were things that we did to start evolving into whole person care. And one of the things that we trained all of our community health representatives and our community health workers is they had a list of questions, and they went in to ask the questions for our community members who couldn't ask them. So the first question was, have you asked, or has it been asked, who is or who will be the decision maker in the family regarding healthcare issues? In Ruth's family, no one was ever involved in her care, but if someone had bothered to ask, it would have included her entire family, but the decision would remain with the eldest matriarch of the family, which would have been my mother. The next question we ask is, are there traditional healing or herbal remedies used in your family? Ruth was never asked about any traditional remedies, which may have impacted her care and or quality of life. The third question we ask is, as providers, are they observant of what type of nonverbal cues the patient and family are portraying? Due to Ruth's trauma, lack of trust, her authoritative relationship, Ruth refused to make eye contact. She appeared to not care about her medical care or never want to engage, which really wasn't the truth. That is the relationship that she was taught to have with that authoritative figure, but nobody ever asked. The fourth question we ask is, what role does faith or spirituality play in the patient's beliefs, influences, or behavior? In our family and our community, spirituality is entwined in many different facets. Some of that is the effect of boarding schools and the forced Christianity, but we still have drumming and singing, burning of sage, and it is oftentimes mixed into what is portrayed as a prayer, but it's a blessing. None of those things were ever asked of her. And the last thing we ask is, are there certain terms that are used to describe illness or terms that are considered taboo? In our family, death and hospice don't exist. We are in this current journey that we are in now, and when we are preparing to move on, we are preparing for our next journey. That would have been really helpful for our family to know that the hospital was sending her home on hospice. It wasn't understood at that time. So I share my story because that's why I'm here. I'm here to help bridge the gaps, and I'm here to help us all put an arm around things that maybe we don't understand and ask questions that maybe seem a little uncomfortable, but are so necessary to engage our patients in their own health and well-being. And that is my story. I thank you, Andrea, for letting me share.
Thank you so much, Jenna. That was such an important story. And I really hope, I haven't seen the question yet, but I really hope we can get those questions maybe shared out with the audience. They might really like to see those. And yes, we can share that for sure.
Wonderful.
Thank you.
Thank you.
Yes, so appreciative of that and your time and your story. It's so important and so relevant. We're going to transition over to, I like lots of transition words here, over to our last panelist. And Tawna Reed-Tohmas is who I'm introducing from Compass. She actually received her master's in mental health counseling in 1993. She focused her career on those with severe and persistent mental illness and health conditions. She has been involved with PACT, the Program of Assertive Community Treatment, an interdisciplinary team model, since it was adopted in Washington back in 2007, and it was called ACT. She has always had the fortune of participating in the development of integrated care, including coordinating primary care in a behavioral health setting. So She's already incorporated SUD as well, and employment and housing services. She's currently continuing to serve her career passion at Compass. So thank you. And Tawna, I will pass it on to you. Well, I will do your slides.
Thank you, Andrea. I'll try to keep
You're
us
welcome.
long in essence of time. So we can start with the first slide here. And as Andrea mentioned, I'm going to talk about shared care planning more from my lens, what my experience has been. So I thought of it in providing two aspects: planning the share, which would be implementing, and sharing the plan, which would be really the process, the nuts and bolts of the meeting. Next slide. Planning the share. So implementation, you're really asking yourself, how are we going to do this? What are the pieces we need to have in place? What is the foundation that is solid that we need to have in place to move towards the process, which is sharing the plan? That's the actual meeting. Next slide. Sorry, next slide. Yeah. Planning the share. So it's really important to understand not one size fits all. There's as many options here as there are people listening, and probably more. And what's most important is you move forward, you try it, you look at it, and you revise as you go. It's just as a shared care plan is, it's a living, breathing document. So you keep moving along, trying things out, see what really fits for your agency. That's the important key to all of this. What fits for your agency? Next slide. So in this, we think of some components. It's not an exhaustive list, but it'll give you a framework. So coordination is really the how, location is the where, inviting and engaging participants, the who, tools to document what, sharing and follow up a plan is the when, and tracking of progress. So this is how you'll plan for your agency to provide shared care planning. So in detail, the coordination, these things to think about here are, who are the change agents? So there's some key people here, and one would, or first would be your coordinate. Who's your like go-to person? Who's really organized, kind of gets excited about things, can really follow through on a system? That could be a program assistant, it could be a medical assistant, it could be, you know, a clinician. In all these, it's not really the role, it's more who's filling that role. And as people come, go, you still want to look at those key characteristics. Who will facilitate? So these are the people facilitating the meeting. Who's going to do that? Who's excited? Who likes change? Who's, you know, a cheerleader and can really get behind what you're trying to do? Then who will oversee it? This person is key. You want a person who's not afraid to fail. And failure, as I see it, is a learned experience. And that person will always cheerlead, carry the torch, you know, really kind of look at things and adjust. There are no failures, they're a stream of successes that get you to where you want to be. Then you want to look at what population you'll be serving. Do you want your whole agency to do this? Do you want just one site, you know, or by diagnosis? What population would you want to start with? I would suggest starting with a smaller population, kind of trying it out. I was in a mental health agency, and we tried it out by first looking at hypertension. That was our target population. And so what that did is it really brought us together. We learned a lot about each other. It was at the same time we were bringing a PCP in, and we were able to really kind of start that integrated care process along. Next slide. So you want to think about location. This has changed now with COVID. We have a lot more opportunity, really. People are learning more virtual technology, probably more than we wanted to. So you want to know what technology is available, and then can your staff use it? That's the most important thing. What conferencing tools are you going to use? Teams, Zoom, you know, have that all laid out, and then trial it. What one does your team like? My team liked Teams for some reason, but it's different with each group of people that's going to work with it, but just make sure it's something they can use. And then in person with COVID, we have some extra precautions we have to think of in the sense of your flow, your space. Do you even have the space, the PPE, the protective equipment, and then really how comfortable are people meeting in person? So there's some extra things to consider for the in-person meetings. Next slide. So inviting and engaging participants. So what roles should be present? Do you want to standardize this for your agency? Do you always want it to be, you know, the PCP, the primary care provider, the clinician, the parent? Who do you always want involved, or do you want that individualized or some kind of combination? And think out of the box. I mean, we can have our traditional roles of parent, caregivers, you know, client, primary care provider, but there's also the non-traditional roles of the people involved in the client's life. So maybe it's a EMT, an emergency tech, or maybe it's, you know, the neighbor is really important. But the most important thing here to hand down to the staff facilitating is who's important in that person's life that can make a change. Who do they want there? How do you engage people? So not only internally, but externally. So you want to elicit change and motivate people, be excited about it, educate them on what you're trying to do. I find that people want to help, they're just not sure how. And if you set clear expectations and have answers to all these questions that we're asking, you'll be able to tell them what you want. And then people are more willing to participate if they know what's expected. Next slide. So some key components to the plan, which documentation, always important, as Andrea pointed out, would be, again, individualized, but you really want to look for how user-friendly it is. And our EHRs have many options, so ask, see what's out there, see if you need to create something yourself. But you basically want an area of focus, so the general category, then room enough for goals, not 3 or 4 words, but you know, a couple sentences so everybody really gets what the goal is. And then a point mark or a trigger for strengths and resources. You want to make sure those are inclusive. And then whether it's bullets or it's numbers or something that really is clear action steps that kind of assists the team to have those clearly written out. And then something that has timelines. Again, have people try this out so that what is going to work for them. Next slide. Sharing and follow up a plan. So it's a shared responsibility. You want to think about how copies are going to be shared, ensuring HIPAA is at all points. So it's going to be hard copy, electronic, combination of both. How are you going to do that? And then follow up. Do you want it to be standard in your agency? Do you want it to be, you know, every 3 months? Or do you want it to be individualized per the team, or maybe, again, a combination? It's important because how will that be tracked? You don't want to just say, I want this done every 6 months, or it's up to you. You have to really have a system in place that's going to follow up and track it. Otherwise, it'll just kind of fall off the radar and not gain momentum. Next slide. So tracking of progress, this is really a key component. It's your data collection. How are you going to collect the data? How often? Really depends on what you're measuring. How are you going to review it? What are you going to do with the data? You could be sharing it with a board. You could be, well, most importantly, you need to use it to come back and see where areas of improvement would be. But you really need to focus on what are you trying to achieve with the shared care planning. I like to do the PDSA model, the plan, do, study, act. And when you act, you're really looking back and saying, what have we learned? Where do we go? So sharing the plan happens in all phases of care. This is actually the process of the meeting. I'll keep trying to speed along. Go ahead. Next slide. And you're going to have partnership, acceptance, compassion, evoke spirit, and closure. Next slide. Partnership, that's your intro. That's where you want to set the tone. And remember, the client's the expert. All the participants are experts, and you really want to call that out. It's a shared responsibility. Make sure it's clear that the client owns and drives the plan, and that you're all in this journey together. Next slide. Acceptance, with review of confidentiality and just simply stating this is a safe setting. This is where you can be heard. It's safe here. We can all share our views. You want to meet the client where they're at and facilitating. Make sure you're really present so you can know, are you 2 steps ahead, 2 steps behind? Is someone else you want to keep present? And then you want to make sure there's a respect of all the viewpoints there because they're all valuable, and acknowledge everyone's contributions and how important they are. Next slide. Compassion is an easy one for us. We can go one back, sorry. we start on a strength, then we draw upon that. So it's one thing to say Joe is a friendly guy, but it's the next thing to say Joe's really good at keeping a mood chart and bringing it to the meeting every day, and or every week, and we review it. So that's something you can build on. It gives you a strong point, a strong start off. So you want to make sure you're showing an understanding, and that there's a shared understanding of who's going to do what is your role, not your title, I'm a nurse. How do you impact that person's life during this process? Next slide. You want to evoke by identifying goals and action steps. This is the most exciting part. I try to have a whiteboard or something so everybody has ideas and you're writing them down, and then you can kind of narrow them down and really come up with those bullets. You're eliciting ideas, not just, you know, you'd ask the client a goal, not just where do I want to work, but what do you like about work? Identify and utilize the strengths. And next slide. Last one, closure. You want to reflect and wrap up. So summarize, make sure it's clear steps, revise them if you need to, go back to your whiteboard, summarize who will do what, when, and where. And then you will want to make sure everybody has their shared information so that there's an ongoing dialogue, and set your next meeting. The benefits of shared care planning that I have found, next slide, is it builds relationship. I've had so many opportunities and met so many neat people. Increase your knowledge. I've learned so much in the medical field. Most importantly, patient satisfaction. The person is feeling like people are there to help them. It's their plan. Efficient time and money. We're not all doing different or same things in different areas. And most importantly, community strengthens by you having the same people, and you identify gaps, and some really creative solutions start to come out of that, and that leads to improved health, which is a goal of integrated care. I wanted to leave with you this quote from Helen Keller, if you want to read it to yourself and think about it and see what thought it really provokes for you. Sorry, that was really quick, probably not quick enough, and thank you.
Tawna, you did a great job, and I'm sorry, our timing was a little off. That's bound to happen. But you know, that was such great information. I'm going to transition. I know that we probably have to move on and give folks a break. Is that kind of where we're at, everybody? Or should I take any questions, or are we going to do that at the end?
Yeah, I think we have a couple minutes until our next presentation. I think there were questions about what tools to use and how to introduce cultural competency. So it sounds like this is definitely a topic that we have space to follow up on, and you know, provide additional resources which we can add to our the MCO website. So
yes, and I can answer the question. Somebody asked if we were referring to something that a program at DSHS, I think is what you said. And we're not referring to share and care program. So somebody asked that, and no, this is a shared care plan that is just a template, basically a concept of and a strong part of integrated care. So I just wanted to answer that real quick.
Andrea.
But,
yeah,
yes, no problem.
So any of the other questions that we have, we'll follow up. We do have your email addresses if you have submitted questions, so feel free to put those in, and we'll get back to you all. But to keep us on schedule, we're going to go ahead and jump into the telehealth presentation.